Funding for this program is provided in part by the Minnesota Arts and Cultural Heritage Fund and the citizens of Minnesota.
From KSMQ Television in Austin, this is On Cue, connecting interesting issues and interesting people. On Cue.
In 2017, Mayo Clinic Health System, Albert Lea and Austin announced a consolidation of various services between the two locations. Joining me today for an update on other news about healthcare is Dr. Mark Ciota, CEO. Welcome to On Cue, sir.
Thank you. Thanks for having me.
You bet. That was announced last year. Inpatient and birthing services, Albert Lea transitioning to Austin only.
Correct.
How is that transition going? It's been talk of the town, a lot of contention around it. What's the status report?
Sure, I'm happy to update you on that. So first of all, I think the first message I want to get out is that in both communities, both medical centers are going to remain open. There's been some misfacts about that. The transition's gone well so far. We moved the ICU from Albert Lea to Austin. That was this fall. And we are currently renovating space now on both campuses to make the next move. The next thing that will happen is the inpatient surgeries will come over here to Austin. And then we'll continue with the transition over the next year and a half or so.
And so when is completion of that expected?
It would be by the summer of 2020 based on what we know right now. It's very changing based on staffing, construction availability, construction staging. The weather has something to do with that, but we'd like to be done by 2020. We may have to delay that based on some of those factors, or in fact move that timeline up based on some of those factors.
Is there a relation, I wonder, during this process, maybe separately from it, but other little clinics have closed, Adams, and so folks on the outside might be thinking, drip, 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 what's the end result? Are we really heading towards closure of more facilities?
Right, and the closure of the rural clinics, the smaller clinics, I think is a symptom of rural healthcare nationwide. We just have a shortage of physicians and providers to work in those communities. When we close those clinics, like when we close Adam, those are very difficult decisions, but if we have a clinic in a small town, we want to make sure that it's there and provides excellent care. And if we don't think we can do that, then we don't think that's best to keep it open. We don't have any plans to close any other of the small clinics today as I sit here. But again, this rural healthcare landscape is changing so quickly that these things kind of come up and we have to deal with them as they arise.
It's changing because there are fewer people living in rural areas. That is, the volume of patients to be seen by doctors is going down? There's
a decrease in population in those areas, and then it's just much more difficult to recruit physicians, nurse practitioners, and other healthcare workers to work in smaller towns.
And let's talk about that. I had that on here. I've heard you've talked about that. Others have the difficulty of recruiting doctors. Didn't used to be that way. I mean, it used to be your doctors finished and they would come to a small town and stay for their whole career. It didn't seem to be such a problem. Is it that the lifestyle, or is it that the business that they would enter into in a rural community is just not conducive? They just don't want to go there.
I think it's a combination of many factors. There's certainly a generational difference between physicians that come out of training that we see now and say 20 or 30 years ago about their expectations about how their lifestyle will be, how available they need to be. And I think the days of a physician moving to a small town and being that town's physician for their entire life, entire career are probably gone. The job of being a physician has changed drastically over the last 20 years. The amount of non-physician work that physicians are asked to do as far as paperwork and government regulations, all of those things are adding to burnout of physicians. And it's difficult to recruit physicians really to any rural area, but especially very small towns, to be a single doctor in that area.
Is there a time requirement that they spend with each patient? Like they have to get their quota up of patients? You hear that Is that a burnout factor?
There's not a time requirement, but there's certainly demand, and they have to provide access, and so that's what causes the burnout. There's more demand for their time than is available, and a lot of the time that physicians are spending now is not patient face-to-face, which I think is what most physicians enjoy. It's a lot of regulatory paperwork and computer work.
Mm-hmm. A couple of years ago, might have been before your tenure as CEO, but the system, Albert Lea Austin, went to a program, I can't remember what you called it, but more of there's going to be specialists and you might not see your doctor as often, but you'll get the care you need. And we're going to shift to a different kind of model as far as treatment in order so that you have better access, but it might not be with the doctor. How is that going?
That's going well, and we continue to move on. That's a team-based approach where there's 2 or 3 physicians, some nurse practitioners that help them, and then several nurses as a team. And so then depending on what the patient actually needs, they may need to just see the nurse or the pharmacist as part of that team, or the physician. The idea there, though, is that the physician can manage more patients at one time and do it in a better manner than if they had to do everything by themselves.
Okay, thanks. We're talking with Dr. Mark Ciota, CEO of Mayo Clinic Health System, Albert Lea and Austin, about important issues regarding healthcare. What earlier this year you unveiled the big new computer system?
Right. It's called Epic, which is the brand name of the electronic medical record, and that was we went out live with that in November.
So it's an epic success.
How's it going? It was very challenging. It's a major project. It affects all of the Mayo sites, and we've been rolling it out individual sites or areas. So it's going well. Mayo Rochester will come on board this May, and then Scottsdale is in November. Then everybody will be on the same platform.
And how does that make it better? How will it be better?
All of the Mayo patients then will just have a single Mayo patient number, as opposed to an Albert Lea number and an Austin number and a Mayo number. So you'll have your Mayo Clinic number, but then all the information about you as the patient is immediately accessible to everybody that works for Mayo, physicians, nurses, and so your medical record and your information is easily shared. And so as you move through the system, you don't have to worry about your information going. It's already there. And it's also very good at helping us with our quality. So if I want to prescribe a medication for you, it knows what your allergies are, and it'll tell me this drug may not be the best for you, consider this drug. And so it helps with some of our decision making as well.
Okay, so that could be why, personally, why I got a real quick turnaround on a lab test this week that would normally, I wouldn't get that information so fast. It was like I barely got home and I had a note from the doctor explaining everything and in plain English, and I just wondered if that was maybe because of that.
That's part of it. So when patients interact with the system into the portal is the word we use when you come into it, that's much more robust than we had before as far as what you can do there, what you can see, how you access the system. That's a much better improvement from the patient's perspective.
Are there more workers, that you need in order to make that system work, like more computer programmers or IT
Yeah,
people?
it's a very labor-intensive, to keep that up and running, but certainly well worth it.
Sure. What about back to Albert Lea Austin? When you're done, when the whole transition's done, I forgot about asking this before. What number of jobs will be lost or gone away? What do you think?
I think that when we're all said and done, if you look at Albert Lea and Austin as a single unit, which is how we view it, that the number of jobs will be nearly the same, maybe plus or minus 10 out of 2,000. We have about 2,000 employees. The work will be different, and some will have to shift around, but the total number will be in that ballpark.
You mean those people will be sent to Owatonna or to work or something? Or
no, they certainly can work in other parts of Mayo, but I think we'll have plenty of work for the employees that we have on both campuses.
Is the clinic model, is it more akin to, I think of the market? Clinic makes the market, brings in the patients, brings in the providers, they each charge a fee, the clinic charges a fee for those services. Am I getting that right? as far as what the clinic's purpose is in existing?
The clinic's purpose is to organize and make sure that all of the parts work together so that the patient has a good experience. It oversees all of those parts that you just mentioned, but those parts aren't separate. They're all owned by the clinic. They all work together. And so the clinic's responsibility then is to make sure that the patient experience from the beginning that they access us till the end of their treatment is seamless and safe.
You're making a big investment in mental health in Albert Lea. Talk about that.
Right. So mental health, as I'm sure you're aware, is underserved currently nationwide, and especially in the state of Minnesota. We do not have enough beds for the number of patients in the state that we need, and so we're going to be moving our inpatient psychiatric unit that we currently have in Austin to Albert Lea, to a newly renovated state-of-the-art facility, which will be in the hospital in Albert Lea. And that'll be combined then with Fountain Centers, which is already over there, which is addictive medicine. Many of those patients have what we call dual or two diagnoses. So we think that that'll be a place for those type of patients to get all of the care that they need. It also makes it easier for us to recruit physicians and other healthcare workers to a center like that, where they have more experience and more patients to treat. So we think that'll be helpful in recruiting.
Because that's the same as the doctor problem, right? There
Right.
aren't enough, there's a shortage of mental health workers. Is that because the need has risen so much, or people just aren't going into that field of study?
I think it's a combination of both. Certainly, I think the demand exceeds what we have available for access, both in the state, nationwide, and locally.
And in the rural areas particularly, mental health is really still not talked about very much, but it's a huge problem with farmers and so on.
It's a huge problem for everyone. You're much more likely for someone in your family to need mental health services than you are to have, deliver a baby or have an overnight stay for an inpatient surgery. And mental health, even though we're moving the majority of it over to Albert Lea, in Austin, we're having a program which we called integrative behavioral health, so that if you come in to see your family practitioner and have a discussion and turns out what you need is really a mental health professional, those professionals will actually be up in the family practice clinic and you'll be able to access them right then. They might just come to the same room that you're in. Or you go down the hall and see them instead of having to wait 2 weeks for an appointment or going to a different building. You actually embed them into the team that we talked about earlier.
And is Epic, might that help create that environment? Is that part of that computer system built to do that?
It is, managing patients and what their diagnoses are and who needs to see them and how they get seen.
Ira Moscovitz leads the Rural Health Research Center at the University of Minnesota, and he came down for our show we did on rural healthcare. That's all he does is researches it. And he thinks that's a real long-term bugaboo that needs to be addressed more thoroughly by Mayo, the issue of the rural health workforce shortage, that is going to just continue to snowball.
Right, and so what a couple of things that we've been involved in here with Riverland is providing scholarships and training and equipment to try to so-called grow our own workers. We think that if we have local students that we can train in our system, they're much more likely to join us once they graduate.
Funny, that's what we do in television here
Yeah.
too. We try to find local folks who want to stay here.
So we're big supporters of Riverland, the scholarships. We provide teachers for some of the programs. And the same thing with physicians. Mayo's just doubled the size of their medical school to try to create more physicians for the future.
And then he also was concerned about, and we talked about this in our past show, population health, and what that we need to look more closely at that genre or strategy as part of what he called addressing social determinants of health issues. That's probably something that you know what he's talking about, but we're talking about safety in your community and so forth.
Right, and again, historically, health care has really been sick care. You wouldn't interact with the healthcare system until you got ill. And that's the model that was built in this country until just the last decade or so. And now, as healthcare facilities, we want to go out proactively and try to keep individuals and patients from becoming sick. We almost want to put ourselves out of business, so to speak, by having people so healthy. And that's a new thought process for the healthcare industry, is trying to prevent illness. And that's what he's getting at, is how can we interact with our community? How can we work with our communities locally for some of the things that we know cause detrimental health, and how can we help prevent or improve those so that individuals don't get sick in the first place?
Those and things that on their face might not look like a medical or healthcare issue, like safe streets or sidewalks that aren't broken, food supply, quality food supply, that kind of thing?
Those kind of things, and childhood obesity comes to mind, there's an epidemic of childhood obesity in this country, and we have it here in Albert Lea and Austin. And what we know is if those kids don't get counseling and try to change that lifestyle, they're much more likely to be diabetics early. And so that's a burden then on the whole healthcare system. So what is it that the medical center can do to help prevent or help curb the number of childhood obesity? And there's all kinds of things like that. Gun safety, it goes on and on. And again, that's not something that 10 years ago we were asked to do.
And that might be as valuable as a brick and mortar hospital or clinic or something.
Yeah, or more valuable.
Federal funding, healthcare changes, with the new decisions to go kind of away from the Affordable Care Act in the new Congress and the new White House administration. By the time those changes get made, does that trickle down into your world much that causes problems? Or by the time it gets to the clinic level, any changes on the federal reimbursements and all that stuff is handled somewhere else, or is that a headache?
No, it's has direct effect on us locally. Decreased reimbursement from the federal government, both Albert Lea and Austin, about 68% of our patients are government patients. And so we are heavily dependent on government funding. And anytime there's a decrease in that funding, that has a direct impact on what we can afford to do or not afford to do. And so that's one issue. And then with the Affordable Care Act change, we see more patients now that don't have any kind of insurance. They used to have some government-based insurance, but now they don't have any, so that becomes charity care. And we still see those patients and treat them, but we don't get any reimbursement for them at all.
So what's the solution? Don't you need more consistency? Just tell us what the formula is going to be and then we'll live with it. Or do you need constant revision and looking at the federal to change?
No, consistency would be helpful because it helps us plan our systems to treat patients. But as I mentioned earlier, these things come up and we have to adapt to them to keep seeing patients and continuing to provide the care and fulfill our mission. And we will continue to do that. It just becomes more challenging. And that's one of the factors that brought about these changes in Austin and Albert Lea. These are, they're difficult changes, but we feel that if we don't start to do some of these things, we will jeopardize being able to offer care locally. And that's what we want to do, is have good care locally.
And what's been your relation? How do you relate to the city of Albert Lea, for instance? They're inundated with ideas about taking the hospital back and finding somebody else to come in and run it because they're upset about losing the inpatient. Where's that at?
Yeah, and in retrospect, I should have done a much better job initially of educating both Albert Lea and Austin about what our issues and our problems were. So if I had to go back and do it again, that's one thing that we could have done much better, is communicate up front about what the actual problems were. And then we made the announcement, and since then, as you know, there's been some very robust discussions, and I understand the emotion that's attached to that. But as we've moved forward now, we've been talking with the city and the county. We've had some facilitated dialogues, and we're starting to come out with some work groups to start to work on some of these issues so that we can move forward. we have a commitment to both Albert Lea and Austin to be present, to be a major employer, and to provide health care into the future.
The term critical access hospital, it's a level of service, a level of care. Do you need that distinction? Is that necessary to survive in a rural area, that level to be a critical access?
Being a critical access hospital certainly helps because the federal government reimburses critical access hospitals differently than other hospitals and at a higher rate. But there are requirements to be a critical access hospital, which Albert Lea and Austin cannot meet because of our proximity to other hospitals.
Oh, okay, so it never was, it is not one.
It is not one, nor can it be one based on the current federal law.
Other ones in Mayo, New Prague, Cannon Falls,
Falls, yes. And there's a couple that our Wisconsin colleagues have as well. And you have to be a certain number of miles from another hospital, have a certain demographic of patient that makes you a critical access hospital.
So it's more a question of geography and not on level of service that you provide?
Exactly.
Okay. What's the next step? After this transition's done and you're doing the mental health expansion, what's on the horizon for Mayo Clinic Health System, Albert Lea, Austin?
So I think once we get all of these parts together, then I think the patient experience will actually be better, because I think you'll be able to access higher specialty care than you can currently do on each separate campus. Our whole goal is to try to keep care local. In my experience with my own patients, they don't really want to go to Mayo Rochester for specialty care if they don't need to. It's just nice to be treated in your own hometown by people you know, with easy parking, but we want to make sure that our quality is just as good. And so I think that once this is done, that's what patients will experience, is high quality, high satisfaction, being treated by people that they know.
We're talking with Dr. Mark Ciota, CEO of Mayo Clinic Health System, Albert Lea, Austin. I'm Eric Olson, and we have just a few more minutes left. And wouldn't it be better, going back to that, to let Albert Lea try to recruit its own doctors? See if they can get them there, compete? What about competition between facilities? Do you feel you're competing against your colleagues like at Mercy, Iowa Specialty Hospital? Are you competing for patients?
We're not competing for patients, but we are competing for healthcare providers. There's no question about that. But they have some of the same problems that we have. And again, I think in the current environment that we're in, smaller communities that try to compete against each other eventually aren't going to stay around in that marketplace. And that's, again, one of the things we're trying to prevent.
What about some employers? What do you think of that model in Austin, starting their own quality pork, starting their own clinic, sort of, and doing their own thing, not interacting with your system?
Right, and the impetus for that is because not just us, but healthcare in this country is too expensive. And they have businesses to run, and healthcare is one of their biggest expenses. And so they're doing what they think is best for their business. And again, part of this consolidation is how can we have services that we can reduce or keep the costs down so that they don't feel the need to open those kind of clinics.
In the minute remaining, let's talk about your healthcare practice for a second.
Sure.
Of medical. We were talking before we went on, there's some exciting things on the horizon in orthopedics. One in particular, tell us about it.
Right, I think the next thing in orthopedics is going to be regenerative medicine, which most people know now as stem cell, but I think it goes well beyond that. There's a clinic in Rochester that's doing a lot of research on that, but instead of replacing your arthritic hip, I see a day coming where we would be able to make it grow back.
Without the need for surgery?
Without the need for surgery.
Oh, wouldn't that be wonderful?
And that science, which has been around for quite some time, has really advanced the last 5 years.
Exciting.
So that's very exciting.
Exciting to be part of that, I'm sure.
Yeah, and again, I think it's not just for orthopedics, but it'll apply to almost all medicine. Dr.
Mark Ciota, thank you so much for your time, sharing your views. Happy to have you.
Yeah, thanks for having me.
And that'll do it for us right now. For On Cue, I'm Eric Olson.
On Cue is a production of KSMQ Television in Austin, nonprofit public television.
Educational, wholesome, enriching and quality. KSMQ TV shows about people, places, things you know. Programs with the family fit, tuned to the source. KSMQ TV, the better choice.
You can access more information about KSMQ on Facebook and at ksmq.org.